But then patient come back next year, has adjacent segment disease. Elderly people, and what do? You do the OLLIF, or minimal invasive, but then you have to connect the hardware posterior to the previous area.
I showed you what we're doing. We published it.
Yeah.
We are using a tube. I mean, it's very long surgery. You need to have a tube. All of the.
So you mean to connect?
Yeah, to connect the
Or
posterior.
sometimes it's a problem because if
No,
the
it's
patient
always
is
a problem. It's it's a nightmare sometimes.
Yes, but sometimes the people are operating in Turkey, in the Ukraine, and I have not the instrument to remove. And
Yeah,
sometimes it was very, very hard
No,
to.
but even for the patient you do surgery, let's say you have a patient that needs
your own patient.
My
Okay,
patient.
let's say
To
start with
remove
that.
this
Let's-
rod and continue fixation.
Well,
for
yeah.
you.
So let me tell you what I do. I told you I don't like to do big surgeries. I like to do small surgeries.
I also.
But then naturally, some people next year come back. They have more problem that you have to solve for
Maybe
them.
left little rods for future connection.
Well, let me show you what we do now. So.
მან ვისკერა თავი არის როგორ უნდა გადააბა ეს ამას.
უნდა მოხსნა ეს როდი.
ამით შეხედე რა შეკეთებს.
So.
ხო გასაგებია, მაგრამ ეს
ეს შეიძლება ძველი ეს კონდეს და ამით შეგიძლია გადააბა.
Yes, but if you have lumbar area, on the TH segment is a
Big bump.
bit higher, and you will get a tight position. გამოვა კანქვეშ მაღალი.
Okay.
Okay.
So let me tell you how.
No, so I mean, if you have lumbar area, okay, but on the where the patient is seen, it's maybe impossible to do.
Okay, well, let me tell you the solution. Okay.
To remove.
No, you don't have to remove it. You don't have to
Yeah.
remove it. That's the solution I'm providing. Okay, so imagine you got a previous surgery and you got the break on, and then this is what you got there, here, up to here, right? You have a previous thing. Do you see those threads there?
Okay.
Next time the patient comes, you literally do the OLLIF here,
Yeah.
you put the screws here, and instead of doing anything there, you literally use this to put outside of that screw like this, and then you continue the fusion that way. All MIS. All MIS, without have to open it. What's the difference? The difference is that you do that surgery in half an hour rather than 2 hours. So, here, this is,
First time I see it.
no, this is coming out. This is coming out.
Nobody has seen it.
Nobody has seen it. You're one of the first people seeing this. So
We have
the screw, the next screw go here, okay, and then there's a rod there. Next year, if I have to fix it, I just have a tubular system. I put it here. I access the top of it, and then this goes in on top here, and then I connect them together without have to open it. And this is coming out in 4 months. It's coming out. It's still not FDA approved, but it's ready. This is what we are going to do. What's the difference? It enables me on an 80-year-old person to do the 2-level fusion, let them heal, come back in 8 months, in 6 months.
Just 1 hour surgery.
And do then another 1 hour surgery, and then help them without have to open up everything or do a Vilsty or anything and so on. It makes the second surgery completely MIS.
Wow.
No, this is one thing that you'll like. The other thing you will like is that, imagine in many of our cases, when we do surgery, osteoporotic patient, you remember, 9 out of 10 times when your instrumentation fails is in S1.
Yeah.
The angle is different, the S1 is weaker bone, and as well the literally shorter thing. I put a bicortical screw and so on, but still a problem. S1 is always a problem. As a matter of fact, many people say that if you get an instrument from L2 or above to S1, always put iliac screws. Iliac screws putting in MIS open, yeah, there are ways to do that. We have done it, we know, and so on. But doing it MIS is a big deal.
To connect road maybe.
Not only that, just put a MIS iliac screw is a big deal. No, we have to have a solution for that. Our solution for that is this. So you make a 2 centimeter incision on top of the iliac crest right here. You feel the fascia, you slit the fascia open, then you put this down. Okay, then you feel it, 2 centimeter incision, you put this down here, you get a lateral x-ray, you see this hole, you put a jamshidi through it, you put a wire through it, and then a guide wire, and then you put these screws across, cannulated screws across, and then you bolt it together. Like this.
From outside, you
From
can fix,
outside,
one
take
screw.
2 minutes. Take 2 minutes to do that. Then all of a
Here is only
sudden,
muscles.
then you instrument not to S1 but to iliac crest.
The many must have done
It should
other.
be strong, like as we know, iliac screw should be like longer. Longest,
So-
I mean.
We have done our biomechanical studies. By compressing it like a bolt, rather than just being a screw, is 2.5 times stronger than iliac screw. Yeah, 2.5 times stronger, because that the mechanical things are out there. It compresses here is part of the bone together, like this,
Wow.
like this, like
Maybe they
compression
need to
force.
make
It's really a
some
good thing.
Very clever
punches.
solution.
Make here.
Very clever solution.
And
And then what you have then,
they sit in
yeah, all you need to do, you need to put a S1 screw like half a centimeter
Sorry.
up.
Sorry.
No, don't worry. Don't worry.
No, it was
No worries.
Not a silly.
This is made for this kind of thing. So you have to put only the iliac, the S1 screw about half a centimeter more proud, then they all align here. In the skin, you see the same thing like you see right now. Okay? Which it means that you just pass the rod across and you lock it, but this one is here and it's 2.5 times stronger than any iliac screws that's out there. Now,
So
you remember?
you have to put this one screw a little bit different?
The S1 screw, you have to make it proud. We call it proud, meaning that it's not sitting all the way in.
Okay.
You have to put it like,
Can you skip
have-
this one as well as?
you can, but
you
why
have a
would you?
iliac.
But why would you?
It's done.
Just I mean,
Yeah, you can.
somehow
You can do
maybe it's difficult or maybe there is no.
Absolutely you can, but you know, why would you?
Doctor, do you mean when you use all knee system? But if I make open surgery, it's also possible, yeah?
Say one more time.
Open surgery.
As they open.
Yeah, you can use it as an open
No,
surgery.
you don't see
But-
this, but you can see and make it full.
Yeah, you can do all of that. You can do all of that. But here, it's all about doing it MIS. What
Yeah.
you can add a
Very
MIS, iliac screw bolt, not screw, that 2.5 stronger. It takes 2 minutes to do that. And then,
Wow.
and then you can, no, you remember we talked about the,
Yeah, its tip is different.
no, look at, this is,
Not just
look-
so tip.
yeah, but look at what it makes it what it does, okay? It's a self-tapping, self-drilling, but this cut, you see that there? It doesn't go all the way to the tip. What that means, if you hit an artery,
Wait.
there's nothing sharp about it. Feel it. Feel the thing of it. You feel it's not sharp.
Yeah. Yeah.
Okay, why is it not sharp? Because when you're in the
Make a more
pedicle,
compression.
no,
Oh.
when you're in the pedicle, imagine if you have a sharp thing,
What does
it cuts through the pedicle.
Yeah.
But if you have a dull thing,
It's more straight.
it centers. No,
It's more
it centers itself.
Mm-hmm.
You remember one of my K-wires
Yeah.
was a little not centered on the pedicle.
And it will call it.
This will say
Find way.
It never passes
the
the cortical bone.
push against that, it sent. So this is self-drilling, self-tapping, self-centering, and vascular safe, because
No.
look at the tip. It won't,
It cuts.
it won't cut through the thing.
Even we can-
Putting bicortical screws with this is so much. And see how much higher it is than the screws you use, because I treat 500-pound people. Okay? And look at that here now. Do you see that threads going there? If I need to correct the lordosis or deformity and so on, I put the rod here.
It's like reduction screws
It is a reduction, not like a reduction screw. So self-drilling, self-tapping,
and reductions.
self-centering, vascular self-reduction screw. Has all the features in one, and since it is so much higher, I can have a patient that has so much fat and still can see and control the top of it.
Difference.
Yeah,
What we are doing.
And then, next time the patient comes, this stays in, I don't have to open it up. I can use the outer threads to put the other one here. And then continue the surgery all MIS.
Just you need to adopt this head here. Just
But
you
adopt
need.
what?
It's for releasing of cap of screw. Yeah.
This?
No, it doesn't actually touch the cap of the screw. They push this here and then you can connect the rod here. So
I
this
wanna
always
just
stays here.
like this.
This doesn't.
Okay. Okay.
So
You don't need to touch
you
it.
want to
You're
put
right.
it here,
Yeah.
put right here.
Fracture?
Yeah. Well, don't worry about that. Don't worry. Let me. Here.
This is how.
So, imagine now I want to extend this. Okay.
Yeah.
I just go with the tubing and
Yeah.
then I put that on
Great,
top.
great. Yeah, now it's clear.
Okay.
What he actually, what was Buba's primary question? He was asking if patient is very thin, like there is no soft tissue, there is no enough mass. Maybe sometimes
Is it too
the
high?
transition zone
Too
is
high,
too high,
yes.
and you
Too high,
have
yeah.
a skin problem.
If they're very thin,
Yeah.
you don't need all of
Yeah,
this.
yeah.
You just need to make a small incision.
Yeah,
open it
yeah.
up and
Yeah.
it's right there.
Yeah, it's more easier.
Okay, yeah. This is for 300 pound big people that it takes you 2 hours to get there.
Obesity
So,
or
see,
something.
we have to always solve the problem that
And also,
we have to solve the problem that exists. On a thin person, like you just make a small tiny incision, it screws right there.
Yeah.
Why do you need all of this? You don't need all of this.
But at least you need for this type of patient, if you have a previous 4-level fusion, you need 4 different incisions to release the cap.
Yeah, that would be. You need 4 different incision, or you first, if it's fused, you have the first one, you cut the rod here,
Yeah.
and then put a new screw and continue.
one thing I wonder
Really?
is that
Oh yeah,
how,
they do it all the
You
time.
can cut and you don't need to release also, and
So,
you can just
okay,
remove
let's say-
some part
okay.
of road.
Let's say this is the patient,
Yeah.
and I extend it here.
Yeah.
If this is fused, I open up this, visualize this, cut the rod here,
Really?
take this screw out, put a new screw in, and then continue it as I go. And just cut the rod here.
Okay.
Do it all the time, no problem. But you have to be sure the bone is fused here.
If you are not sure, you need to extend road. You need to release all cap.
Yes.
You need to release all.
If you're not sure, or if it's not fused, then yeah, you can release all the cap, put a new rod in,
Yeah. What we are doing nowadays.
or maybe
Yeah.
use a domino there.
or you can use a side-to-side connector, or end-to-end connector.
How do you cut it?
How do I cut it? It is a
Because sometimes it's impossible to remove because the quality is not good.
It
You
is
can't
a-
remove the head.
It is a special drill bit. It's called side cutter. It literally you irrigate, and then you put the rod cutter here, and that take 10 seconds.
You can actually drill this. If your normal drillers can also drill this.
No, normal drill is going to.
No.
It takes
you have-
longer, but we use
No,
it.
you have a
no,
lot
no,
of-
yeah.
We use a
Yeah.
drill head, but
lot of
you
steel
can
in
do
your
it.
wound,
Yeah.
and it's infection source.
No, so good idea. First of all, not steel. It's a titanium. Yes, you have a lot of chips there.
But
Yeah.
I mean, tip of high-speed reel is steel.
Oh yeah. No.
Okay, you can use diamond, but it's
No. Yeah, it's a special drill. Don't use.
No, just I asked
Like
you
you
this
were-
question.
No, it's a special drill. It's made for this.
Okay.
It is. You have no stainless steel. It's not made of stainless steel. It's a special drill. I think it's a combination of tungsten something else. It's made for this. It takes 10 seconds, but you have lots of chips there. To prevent that, you put a jelly there. You cover the entire tissue with the jelly. Then you have a film of jelly all around the tissue. Those chips, they embedded in jelly, and then you wash them out. I do it all the time.
One thing I wonder is how you pass this part under the skin because you're doing like 3 or more levels to because it's like for
This is for demonstration. The
Okay.
bed is not that much. I put this a little proud,
Okay.
and then I put a much smaller bend here, and so this is a little higher, and then you pass it in. It actual bend. This is for demonstration. This is not real.
smoother than this.
Much smoother than this. It's not like that. But another thing is that you need to know, once you're under the fascia, the muscle gives away to anything. So it's not a really problem to pass that. But why is it important to do this? Because once you are starting doing 500,000 minimal invasive surgery, 2, 3, 4 years later, this
Yeah,
patient come back.
reduce.
You're not making people younger, right? These people are going to age. They're going to have adjacent segment. No, this is all about doing the next level in 2 years, in 3 years, in 5 years.
Even we had
All
the
the
cases, we have just started 4 years, maybe 3 years ago, 4 years ago.
Yeah.
We had the cases when you need to do, I mean,
happens a
redo
lot.
revision.
That's
know,
what
maybe
we
It's
call
a very
it-
good
For this
solution.
type of
That's what we
surgery,
call it
fantastic.
extension ready system, meaning that
Extension
it's
ready.
ready for the next surgery.
Yeah.
Yeah.
For the,
Extension
so,
ready.
yeah, so these are the,
Actually, I never seen. I mean, it's a first thing. I mean,
I have
there's
the patent for this.
alternative.
I'm sure you haven't seen that. We have the patent.
Not another company is doing.
Yeah.
There is no alternative.
But the good news is, we are literally giving this patent. We are going to use that in the United States.
Yeah.
But in the United States, we sell this for $1,000 each.
Wow.
$1,000 each, yes. A surgery of what we just did in the United States is a $120,000 surgery. Just $30,000 material there.
In Georgia, you can say it's a $5,000.
Yes,
Full
but you see
operation.
that, but
in
you see
Iran,
that there.
500.
Don't open our secrets. Yeah.
The point here is that the rest of the world cannot pay
Well
our
said.
prices. That is why we gave all this patent free of charge to India,
Yeah.
so they can build it for you for $100,
Yeah,
$200.
Yeah.
We
Great.
gave it there, literally, we gave it to them for free.
You have done this,
So,
yes.
because India cannot afford it
Yes,
anyways.
exactly.
There's no way they are going to come and buy a $1,200 screw.
No Pakistan and
No,
also
they won't
no
be doing
Georgia,
that. So
no
there is,
Iran.
so it is not, it's really, they make no sense to not give to
Produce,
people
yes.
that they cannot afford it anyways. So hopefully within about 6 months after we are done, this will be probably end of the year or so available from an Indian company. Okay, we don't win anything there, but we wouldn't be winning there anyways because there wouldn't be
There's
able
nothing to
afford it.
win.
There's nothing there to win.
Yeah.
So why hold back to give people a value that they could have? So that is our strategy to, literally is a strategy to give
develop
the rest of
it.
the world a
High
benefit.
quality of medicine
Yes.
and the
Okay, so-
patient has a
For other
high quality
systems,
life.
Yeah.
for other systems, maybe you can make a drill that drills this here, like on these screws.
Say one more time.
Yeah, for other systems, because you have many patients coming from other system fusion with others, you can make a drill head that actually drills here,
So for other system,
just like that.
there are
And you can
there's-
you can put that screw here too.
for other system, we have a system that you see inside. Inside is a cap. We take the cap out, and inside of that replicate their cap.
Really?
Oh yeah,
It's amazing.
yeah. Then you just take this out. You take their cap out.
It's a universal cap? Is
No,
it
it's
like-
not universal. It's a system specific. It has to really lock into that. So, but there are like 90% of the screws you have are like 5 companies or so. You have to have the
a lot of Turkish and
yeah,
Chinese.
no, yeah. I mean, in USA.
USA,
Yes,
but
okay, so
I mean, if you reach to European countries, there's a lot of.
yeah, no. Obviously, this part has to. It cannot be universal because
Okay.
it has to lock and really
Yeah.
stay there.
Yeah.
So, but what we do that we take that and we can reproduce that. Okay, we literally can go machine that. You say what kind of screw it is, they go and
Before
make it.
operation, you have a CT and
that's
Yeah.
base of
part of the
CT you are
planning.
doing. Base of CT?
No, you have to know what it is.
Ah.
Then you have a database that say what kind of cap it is.
Right.
And then you go and create exactly that cap inside of
Now
this.
it's good.
And then this goes.
But if you don't have information about system, Sometimes we have a patient, you don't have any information, any passport, no, there is no.
Then you go to church and pray. That's what you do. If you have no information, you're stepping on a minefield.
Yeah.
So yes, you can get the CAT scan, you can get the high resolution CAT scan, you can do the best you can do.
But we have such kind of situation.
Yeah.
And it's frequent, you know. It's not.
Or you can go do a small surgery, take the cap out, send it to them, and then they replicate it.
Yeah,
You can do that as well.
it's reasonable.
Yeah, that's another possibility.
Yeah.
Now,
Can you use this instrument for
no, before we do that, I want to show you something else though.
surgery, the last level looks like this. The surgery, the last level.
We did a L3 to L5, right? The last level, here's the spine is coming down here.
It's a leaf, yeah?
Am I
Am I
still-
leaf?
I wasn't here. I was here. And I entered, made it horizontal, and I passed all the way through here. So you see the difference is I'm transpsoas, not in cambium triangle, and then I'm transpsoas because if I'm there, it's harder to go all the way to the other side. But if I'm here, I can drop it and then go all the way to the other side and correct the scoliosis there. So we published that paper in 2017, 2018. I have done like probably 450 of those cases. And that enables you, number one, put a horizontal cage in, and number two, if you need to go to the other side, like correct the scoliosis, or maybe patient has radiculopathy on the other side, you go all the way to the other side. Did you see how it opens up? Do we have the films of that? If you can look at the films.
X-ray film.
Yeah, now, yeah, if you have that, if I can
Because
show
how
you
we know
that.
in the X-ray that we are anterior to the root.
Yes, yes, yes. I show you on the X-ray how it looked like. But one last thing I want to show you here is the sacroiliac joint, the side joint system.
It's like X-leaf. It's like X-leaf.
It is like a prone-lateral.
Prone-lateral.
But it's
Prone-lateral.
done.
X-leaf is X-leaf is obviously in a lateral position. Here's prone-lateral is in the.
But I mean, concept is you are going through the psoas mass.
So
But you need
this
maybe.
has a little bit higher complication profile, or you haven't had any experience?
No different complications.
Yes, you need neuro monitoring to
Yes,
have
yeah,
to
of
course
check.
you need it because
Yes,
you're going
I did that.
transpsoas.
Yeah.
I used the neuromonitoring probe to get there. You saw that, right?
Yeah.
So, did I not bring my SI joint stuff here? I would be very disappointed if I didn't. Okay, here. So, sacroiliac joint fusion. So, the sacroiliac joint fusion. So, this is the sacroiliac joint screw, and I put a guide wire here. I have a guide wire there. I can go and get it.
Do you want me to do it?
Yes, please.
ეს არის სტაბილიტი არის ამ გავასა და თეძოს გავათედოს ასარი ხო აგერა გავათედო
So, I adjust for the greater sciatic notch, and I go at that angle here. Once I'm in the right place, I drill this in all the way into the bone. Then the next step is use a dilator. Let's say I'm in the bone, in the final position. This dilator goes in first. This dilator goes next. Then I use a hammer to hammer it in to cortical bone. And I don't like to drill because when I'm the hammering in, I compact the material in, whereas when I'm drilling, I'm removing the material. So it makes the bone stronger at the corner. So once I have done that, all I need to do is to put this in and just start screwing until I'm in the final position. Then I align these two windows along the axis of the sacrum. This comes out. And now this is the actual magic of this system.
Screw.
Look, you cannot lose this. And then, so this is along the axial of the thing. I go put a screw there, put a screw here. So one poke.
Like standalone. Like standalone ACDF.
Yeah. But see, that's the idea, that you don't have to poke it 3 times. You don't have to go back lateral and so on. So you go only one time. Once
Just one guy.
Yeah.
That's it.
Once this is in, once this guide wire is in, it takes literally less than 7-8 minutes to put all 3 screws in, then you're done. Okay, so and then disconnect it and that stays in. So it makes it really efficient, and this is the whole idea here. Look, you don't lose this. There's no way to lose this. And then once you are done, once you have done putting this, you just unscrew it. This comes out, and you don't lose it prematurely. Okay, let's look at